I'd like to welcome everyone to the Buncke Clinic Virtual Visiting Professor Series. On behalf of all my partners at the Buncke Clinic, we are delighted tonight to welcome a very dear friend of ours and a true giant in the field of plastic surgery and microsurgery, Professor Yixin Zhang from Shanghai 9th People's Hospital. I could spend the entire hour talking about Dr. Zhang's accomplishments, but I tried to just narrow it down to a few slides. As we all know, Professor Zhang is a full professor at the Shanghai Jiao Tong University School of Medicine. He is the chief of the Division of Reconstructive Microsurgery, the chief of the Division of Scar Comprehensive Repair, and the vice chief of the entire Department of Plastic and Reconstructive Surgery at Shanghai's 9th People's Hospital. And this department has over 100 surgeons. So we're talking about one of the biggest, if not the biggest, departments of plastic surgery in the world. Professor Zhang did his training and completed his PhD in plastic surgery under Professor Tishan Zhang, who is one of the founders, or if the founder, of Chinese plastic surgery and was one of the biggest names. He then traveled to the United States in 2006, and for 2 years he was a visiting scholar at Duke University under Professor Scott Levin. In 2012, he was a guest professor at the Burn Institute of Southwestern Hospital of the 3rd Military Medical University. In 2013, he was a guest professor at the Hunan Provincial Tumor Hospital of Zhang School of Medicine. And in 2017, he was guest professor at the General Hospital of the People's Liberation Army. Dr. Zhang has been honored with many, many awards. These are just a few of them. In 2014, he was awarded the best plastic surgeon in China. Obviously, no small feat considering it's such a large country. In 2015, he was awarded the research physician for the first session of the Shanghai Municipal Education Commission. In 2017, he was recognized as excellent technology leader in Shanghai by the Shanghai Science and Technology Commission. And in 2018, he was awarded the ASRM Godina Fellowship, and he was the first person from mainland China to have ever received the Godina Fellowship. He has leadership roles in many national and international societies. These are only a few of them. He's chairman of the Asia Pacific Scar Medical Association, vice chairman of the Asia Pacific Federation of Societies for Reconstructive Microsurgery. He's on the academic executive committee of the Asian Wound Therapy Academic Committee Association. He's president of the Chinese Society for Scar Medicine and the vice chairman and secretary general of the Chinese Society of Reparative and Reconstructive Surgery. He's on the editorial board of a number of journals. I won't go through each of them, but you can see that he's very sought after, obviously, for his expertise in plastic surgery, microsurgery, and also scar therapy. We had the distinct pleasure of hosting Professor Zhang during his Godina Fellowship, and we were honored to have him visit us. We had a fantastic time with him and his one of his partners at Shanghai's 9th People's Hospital, Professor Dajang Song. We had a fantastic dinner, as you can see here, and then we were treated with an incredible lecture that Professor Zhang gave us about advances in microsurgery, specifically with the KISS flap and sequential flaps to cover these large defects. And this was really a tremendous visit to not only learn from Professor Zhang, but also establish and continue our very close friendship. And this day, he gave us 1 or 2 lectures, and also he spent pretty much the whole day in the operating room with us, which was really fun. He and Professor Song as well were in the OR with us. And I think one of the most fun parts of his visit was when Yixin and Dr. Buncke in his office were actually going over some of the historical slides that Dr. Buncke has from his father, Harry Buncke. He was showing him a lot of these, and we actually found out through Professor Zhang that his mentor, Professor Zhang in Shanghai, was actually very close friends with Harry Buncke as well. And then he sent us this wonderful photograph of his mentor visiting Harry Buncke many decades ago, and them spending some time here in California, as you can see. So it's a very small world, it's a very small field, and I think these connections continue through generations. And this is a photograph of the two of us at ASRM this past year. And so, Yixin, thank you so much for being with us. It's really an honor to have you. We're delighted to include you in our Visiting Professor series, and we're really looking forward to hearing your talk tonight. Thanks again.
Thanks, Babak. Yes, it's very nice to see you again. And for this very special, yeah, for this after COVID-19 virus, so everything is slowly also in Shanghai. So far, we are almost back to normal. So this morning, so also I'm very honored, yeah, to be invited to share my experience, to everyone. Yeah.
Thank you.
Yeah, you clear? Yeah.
Yes, we can hear everything, and I'm going to ask everyone to keep your cameras and your microphones off during Professor Zhang's lecture. Thank you.
Yeah. So I stand. So when Safa invited me, so I give a lot, so many topics. So Safa asked me to present the prefabric and the pre-expanded flap. So he is very interesting. Maybe some difference, So as okay. So as Safa showed the pictures. So when I in 2018 when I was ASM Godina Traveling Fellow, I visited Buncke clinic. So they treat me very well. So it's very hospitality. My mentor, Professor Zhang, also is a very close friend to Dr. Buncke. Also, the another giant in China, Professor Zhong Chen, also is very close to Dr. Buncke. So we all stand on the shoulders of giants. As the young generation, I visit the Buncke clinic. So we renew and rebound the friendship together. Also, I congratulate Safa as the 2019 Godina Fellow. So now today I gonna introduce the prefabric and the pre-expanded flaps in facial soft tissue resurfacing. So before I introduce the surgical technique, we should know some. So what is the beauty of the face? What is the normal? How to define a normal face, right? So in the history, as early as the ancient Egypt, so the ascetic facial proportion had already been idealized in the arts. So Plato and Aristotle also they define the beauty is in like symmetric, harmony, and the geometry. So their philosophy, they consider what is the beauty of the face. As for the artist, so Leonardo da Vinci, through his study of anatomy, he formulates the idea of facial proportion and divide the profile into equal thirds. So for the poets, philosophy, artists, they have pondered its elusive quality and try to quantify that which is evident to all of us. However, as a surgeon, we are required to have a more scientific approach to beauty and to formulate operative plans with successful surgical outcome. We need a more precise surgical plan. So this is a British surgeon. His name is Walter Yeh. He is often cited as the first non-person to have benefits from plastic surgery. So this photography show him before the procedure and after receiving a skin flap by Sir Hygienist almost like 100 years ago. So this is the patient from Hygienist, but when you see the results of these patients, you see the patient. If you did the flap like this, now in Shanghai, I think the patient will sue you. Maybe will kill you because you can see it's not follow the subunit principle. The color is not match. The texture is not match. So this is not good idea for the face, right? But I always wonder. So this Hygienist, we recognize him as the father of plastic surgery. Why he apply these subunits to the face reconstruction? So what's the concept? One day I found a movie. Okay, maybe at that time, the face subunits. So that means, for the face resurfacing, the concept also for the plastic surgery, aesthetic surgery. So the concepts always, always change and always change according to the needs of the patient. So the idea face reconstruction. So we should, the similar color, the similar texture, the thickness, pliability, and subunits. So what is pliability? Pliability means when you do the flap surgery, so the muscle movements could reflect, on the surface. So this is pliability. So only follow this principle, then you can achieve a normal appearing face. So in 1954, Dr. Gonzalez Una, he divided the face into 9 aesthetic units. So that's a further divide into more subunits, based on the skin thickness, color, texture, and the underlying structure, contour, and the function. So our current concept for face soft tissue resurfacing is a double S principle. The first S is similarity. The second S is subunits. So you follow the similarity principle, then can guide you to find the ideal donor sites. The subunit principle could guide you, also could help you to achieve the best appearance outcome. So double S, S and S. So then according to this double S principle, so we can find the ideal donor site for the face, like adjacent neck area, supraclavicle area, anterior chest area, lateral chest area, and the scapular area. So before I introduce more, today I collect more cases, so I can show more cases. So I know that people like to see the cases. So then before this, I want briefly introduce what is flap prefabrication, flap expansion. So the flap fabrication is a two-stage process. So first introduced by Dr. Zhang in 1981. The first stage is, inserts a vascular pedicle into a body tissue that bears some desired character of the area to be reconstructed. Then the second stage followed is by a transfer of this new vascularized tissue into the defect based on its recent implanted vascular pedicle. So this is Professor Zhang, Dr. Zhang, Zhu Zhang. So he published this paper in 1981. He harvested the 2 branches of the superficial temporal artery, the frontal branches and the temporal branches, and the rotates in the neck area, and the inserts, buried in the neck skin. So after a couple of weeks, so he divides this and the rotates and go back to reconstruct the helical rim. So this is almost 40 years ago. This is the first case of the prefabricated case flap. And then he harvested the descending branch of lateral circumflex femoral artery, into the medial side of his right side. So the first case is lost, then the second case is success. So flap prelamination also is a two-stage process. It's first introduced by Preves in 1994. So what's the difference between the prefabric and the prelamination? Like prefabric is the vessel is from outside. The prelamination is the components, the tissue is from outside. So this is the difference. So the prelamination is one or more tissue are engrafted into a reliable vascular bed to create a multi-layer composite flap. Sequentially transfer on its original vascular supply, unblocked to the site of reconstruction. So this is two-stage. So the first, this technique is introduced by Preves. They published the paper in 2007. They harvest a cartilage in the bury into the forearm area, creates the nose flap, and then the second stage is transfer into the face to reconstruct the nose and the cheek. So when the flap major, so the new vascularization between the implanted pedicle and the donor side and the donor tissue measured normally after 8 weeks. However, the maturation can be hastened by a number of for angiogenetic actors such as basic when you can inject some basic BFGF, VEGF, some stem cell, so that you can enhance the new vascularization. So day 1, when you bury the vessel, then you can see in day 1 the vessel is dilated. In day 6, is newly formed vessel have operized from the implant vessels. And the day 9, the communication it starts of two vascular system have occurred. And the 4 weeks after, so the arrow show newly formed vessels connecting the implant vessels and the original vessels of the flap. So it's measured. So the flap tissue expansion. So this technique could provide an abundance of tissue that facilitates the donor side closure following the final transfer. The second, in the thinner the donor tissue flap, which is help mostly, especially in head neck reconstruction, provides the mechanical stretch that stimulates the endothelial cells to proliferate, thereby enhancing the rate of new vascularization. Focus the direction of the new vascularization from the implant pedicle towards just one side. When you combine it with the prefabricated the vessel carrier, so you enter the vessel carrier, so the stretch is only one side. So this side of the prefabricated flap, so you can enhance the new vascularization. So 20 years ago, Luc Thier from France, he published a paper in Lancet. He prefabricated and vascularized the supraclavicle flap for face resurfacing. And another Dr. Paluha, also he pre-expanded ultra-thin supraclavicle flap for full face reconstruction. So you can see, but he should show the surgical technique is the pedicle dividing the later stages. Also, that published in the paper. Also, this another case. Another doctor is doing the hemifacial resurfacing with the prefabricated induced expanded supraclavicle. He harvested the vessel carriers from the radial forearm and the anastomosis to the facial artery. So then inserts the expander. So the second stage is transfer into the face. But the more time consuming, the more challenging at that time. Also, there is a crazy microsurgeon from Japan, Dr. Sakura. He harvested jejunal serum muscular flaps. This flap is like a segmental vessel vascular supply. So he divided into three segments. So one is for the nose, one is for the lip, and the one is for the face. You can see the final results. The second stage, he reconstructs the upper and the lower lip and the nose. So this is the final results. 10 years ago, the published in Burns. So in our experience, the ideal donor sites, adjacent to neck area, supraclavicle area, anterior chest, lateral chest, scapular. So normally we apply these donor sites for the face soft tissue resurfacing. The first is adjacent to neck area. The adjacent neck area is, we should follow the principles like with like. So the neck area is, more close to the face. So the skin is very thin. However, you cannot doing the pedicle flap. You move the neck area, the flap to the face. So we do the prefabricated flap vascularized. So it's advantages of neck neighborhood in the neck tissue. Also, we should increasing their profile, expanding their tissue volume, and the expansion could stimulate the growth of small vessel in the fascia. So we published this paper like 7 years ago in JIM. So then I show some cases. So the surgical technique is the first is 2 stages. The first step is we harvest the pedicle ipsilateral superficial temporal fascial flap. Normally it's like 10 by 6 centimeters. Then rotate to the neck area. Also, we create a subcutaneous pocket in the neck area to insert the expander. So that you can see, so that for the pedicle, so we wrap around with the silicone or Gore-Tex, but I prefer the Gore-Tex. So for the second, so this is very important for the second stage. So normally, if you without this procedure, so the second stage is very difficult and hard to dissect the pedicle. So if you apply the Gore-Tex, so the second stage, so it's very easy to dissect the pedicle. So then we put some small stitches. You know, this is the margin of the fascial flap. So then normally we insert like a 250 cc to 550 cc tissue expander. So this depends on the how big, how large the size of the neck tissue you can harvest. So initially we initiate at least 2 weeks after tissue step, the first step. So normally 1 week we injected expander 2 or 3 times and until the design volume reached. So we at least 2.5 times its original volume. For example, if the expander is 200 cc, so the design volume we should reach 500 cc. So we need more expanded tissue to prevent the shrink when you remove the tissue expander. Also, long time, so it's the flap, the prefabric flap is more muscularization. So the second step, so the flap you can elevate from the base of the neck. So the size of the flap was normally is 1 centimeter large, larger than the defect to avoid any tensions. So then you can see here there is a Gore-Tex wrap around the pedicle. So this is the whole true pedicle, the flap. Then you rotate the cheek, also the cheek area. You resect the whole cheek at the subunit, follow the subunit principles. Also, the donor side could be closed directly because we have more expanded tissue. So this is the case, is a 38-year-old woman presents with bone scar in his left hemiface. So after expansion, you can see, so the neck prefabric flap is transferred to the face. You can see the nevus originally is in the neck area. So then after transfer, so the nevus is go to the face. So this is the lateral view. You can see the donor sides, the scar is we can hide in the submandibular area, also in the side of the neck. So it's you cannot see this when the hair covered. This is another case is the same technique. So we resect the whole scar tissue, and as the subunit principle, then we do the whole flap, unblock flap. You can see this. Another case. Also for this is bilateral cheek, also the upper and the lower lip. So we can apply bilateral prefabric neck flap. So we rotate the bilateral superficial temporal fascial flap, and we create 2 tissue expander flaps. The second stage, we harvest the bilateral flap, and we resect the whole face. So the 2 or 3 days, so you can see there's still some swollen. This is lymphedema. This is lymphedema. So then the patient a little bit hypertrophic scar. The second donor site is the supraclavicle area. The supraclavicle artery has two branches. One is transverse, one is go down to the chest area. So normally the bifurcates the points is nearly 2 centimeters above the middle points of the clavicle bone. You can see this is the branches to the chest. So that it's better. Also, it's very good for the neck reconstruction after expansion. However, the pellicle is very short. You cannot reach to the face after expansion. So one group of our department, Dr. Lee, he published a paper. He harvested the descending branches of the LCFA and the anastomos, the facial flap anastomos to the facial artery, or maybe suprathyroid artery in the neck. So then put the expander. You can see this. Then, so this technique could reach to the middle part of the face. For the superficial temporal facial flap, pre-fabricated flap, is better for the cheek area. So it's better for the middle part of that. So this is the difference. And this is the pre-operation and the post-operation. So the third donor site is anterior chest area. So we expanded the anterior chest area. So then we follow the microsurgery to reconstruct the upper and the lower lip reconstruction. So before the surgery, so we do the color Dopplers. We find that the second intercostal perforator is better than the third intercostal perforators. It's more big, and the go into the flap is more far. So according to the pre-surgical color Dopplers finding, so we find that there's two sub-perforator from the second intercostal artery. So this is very important information. So we can create the oral commissure in the same stage, and to avoid the problem of the distal part of the flap. So this is the post-operation. So the donor site could be closed directly. Also, the two nipple position is more symmetric. Also, this is very severe burn case. Burn case, we put the expander in the forehead, in the left cheek. Also, we put the expander in the anterior chest area. So the second stage, we dissected the whole, in the right side, the whole scar tissue, and release all the conjecture. So then we harvested the pre-expanded IMAP flap. So this flap we elevate above the expander fibrocyst. So we need more thinner flaps because we need more pliability of the face. You can see the second and the third intercostal perforates. So then, according to the defect, we can tailor the IMAP flap. So this is then after surgery. So also we still put the expander in the forehead for the second stage for the nose reconstruction. So the chest could be closed directly. Also, another case is the hemiface defect, soft tissue defect. So we put the expander. Before surgery, we do the CT angiography. So then we select which is the best perforate, intercostal perforate. So this is second stage, and we, according to the defect, we tailor the flap. You can see the final results. Also, the donor site, the patient tattoo. This is the dragon tattoo, the scar. So it's really beautiful. So the fourth donor site is lateral thoracic area. So normally you can see the anterior chest area. This is not good donor site for women. This is more sexual area. So for men, it's okay. You can expand the anterior chest. For the woman, so you cannot do this. So now then we find that the lateral thoracic is more, not obviously to see the scar. So the lateral thoracic area is the dominates vessels is the thoracodorsal artery and the lateral thoracic artery and the accessory lateral thoracic artery. So we normally harvest the cutaneous branches of the lateral thoracic artery and the vein. So then we put the expander under under the vessels. So we expanded to the second stage. We can reconstruct the lower and the submental area. So the larger thoracic area is better for the woman or for the girl. The fifth donor site is scapular area. So everyone knows the scapular and the parascapular free flap. So a lot of advantages. It can provide the large skin paddles. Can also include the latissimus dorsal muscle flap. Easy to harvest, lower donor side mobility. Also, sometimes you can harvest the scapular bone, or sometimes can combine the ribs. So the disadvantages is in the back areas, the tissue is very thick, right? So we need expansion. Also, in the scapular area, we can have a lot of variable flap design, scapular and the scapular flap combined with scapular bone, scapular flap combined with parascapular flap, or scapular flap, parascapular, and the scapular bone, and the scapular flap combined with latissimus dorsal flap. For this case, you can see the patient with the neck bone the chin area was erased. So also it's very short chin area. Also the mandibular the chin area is not developed. So we harvest the scapular flap and combined with the scapular bone is a chimeric style. This is the post-operation. You can see the large review. You can see the cervical mantle angle is created, right? So normally we need at least 3 centimeters in the submental area, so then you can create the more beautiful cervical mantle area, mantle angles. Also, for this, we also wish to follow the subular principle. In the lower lip and the chin area, so we need the flap. We try to avoid the avulsion of the lip after reconstruction. For the submental area, so you can do the flap, also you can do skin graft. For the anterior neck area, so normally you can choose the skin graft. So lower lip flap, submental flap and the skin, anterior neck, skin graft. For this one, you can see the scar contracture involved the lower lip, submental, and the anterior neck area. So we do the scapula combined with the parascapular. So before the flap transfer, we do the genoplasty, and we did the plasmaplasty to deep the cervical mantle angle. So we create the angle so you can achieve that appearance post-operation. So then we harvest the scapula and the parascapular. So one is for lower lip, one is for the submental area. So this is the right post-operation, and the 2 years post-operation. You can see very good contour of the submental area. But the problem is when you harvest the scapular flap, also the parascapular, you cannot close the donor site. So then you need the expander, you need more tissue. For this one also, you can see the scar contracture is involving the lower lip, also the neck area. So we put the expander in the scapular area. Also below this expander, we put another expander because we need more scapular tissue. So we need a whole scapular tissue. So when you harvest before the surgery, you cannot close this. So we need a sequential expanded flap to cover the first expanded tissue. So the second stage, we harvest the parascapular and the scapula. So the donor side cannot close. So then the second expanded tissue which is based on the posterior intercostal artery perforates. Then you can harvest this. Then you can rotate to the donor site. So the donor site could be closed directly. So this is the post-operation. You can see the donor sites. Also, you can see the lower lip and the neck here. The same technique for the lower lip and the neck. Put the expander. So this expander we can create. You can see the parascapular. You can reconstruct the upper lip area. Also the lower lip. You can see we we design like this. Also, this is a scapular circumflex. We put this like we transfer like the supercharge technique. You can see the flap. So then there's a purpose in the back area. So this is from the cervical, the transverse cervical artery. So then rotate to the neck area. So then anastomosis to the facial artery and the vein as the supercharger style. So this is the post-operation, the lateral view. So in conclusion, so we can find the neck area, supraclavicle area. So it has more, similar color and the texture to the face. Also, the thickness, the pliability, the neck area is the best. So the neck area is better for the cheek reconstruction. Also, it's better for the submental reconstruction. Supraclavicle also is better for the cheek and the submental. Scapular is better for the lower lip, chin, and the submental area. So the anterior chest is better for the upper lip and the lower lip reconstruction. So when you review this, all the cases, you can find the neck, the supraclavic, anterior chest, the lateral chest, the scapula, this kind of donor sites. We all use the surgical technique is prefabric and the pre-expanded technique. So this technique is better for the face soft tissue resurfacing. So another potential donor sites so far we used is the forehead flap. So this everyone know this is for the nose is better. Also the scalpel. Sorry, I type wrong. You can see this patient we put the expander under the scalpel, right? So we reconstructed the upper and the lower lip. After expansion, before the surgery, you can see the parietal branches, the parietal branches of the superficial temporal artery. So it's easy. You can design the flap according to the course of the vessels. So then we resect all the scar tissues according to the up and the lower lip subunits. So then we reconstruct this with this flap. So then after second stage, you divide the pedicle and the debulking. Also, you create a philtrum. Also creates you can see the contour of the flap. It's quite nice appearance in the final results. For the multiple subunits defect, so I will show another cases. For this patient also is bone cases. You know, in China we have a lot of bone cases. In US maybe have a lot of gun shots, but we have a lot of bone cases. So this is like the patient, you know, the defect is involving the nose, in the upper lip, lower lip, also some partial of the cheek area. So the first stage, we put the expander in the right and the left cheek. This is just normal expansion. Also in the neck area, we try to remove the scar tissue. So this is the first stage. So then the patient asked to reconstruct the upper and the lower. So then we put the expander in the scalpel area, also the forehead area. So we expansion. You know, normally I introduced it before. So normally we need like 2.5 times of the original volume. So this is a big expansion. So then we we harvest the flap, and we resected the upper and the lower lip, follow the subunit principle. So the second stage, we divide the pedicle. So the patient then puts an expansion again, because this is not follow the subunit principle. So then we after expansion, we leave the scar in the nasolabial. So then the third stage is we do the forehead flap for the nose reconstruction. The nose reconstruction. This is the final results. So we need the multiple procedure to reconstruct the multiple defect. Also for this cases as a woman, so the defect involving the nose, upper lip, and the lower lip, and the cheek area. The same, we put the forehead flap. We put the expansion in the forehead. Also, we prefabricated and pre-expanded the neck. So the first stage, so after expansion of the forehead area, so we try to do the upper lip and the nose at the same time. So before the surgery, we do the thermal imaging. You can see the bilateral supratrochlear vessels. So based on this, so you can very precisely design the forehead flap. So then this patient, so we do bilateral supratrochlear flap. One flap is for the nose. One flap is for the up lip. So this is the stages. So then we try to transfer the neck prefabric flap for the cheek. You can see the flap is pure pedicle flap. So this is the final results of the patient. So making the abnormal normal again, that means it's a functional recovery, aesthetic appearance, and the psychological. So the patient can go back to the social activity normally. So this is the normal. Also, this is the electrical injury pre-operations. You can see the defect in the bone exposure. So we did a skip flap for the temporary recovery of the bone exposure defect. So this also we reconstructed the inner lining of the nose. So after the skip flap harvest, so we cannot close directly. So we do the sequential flap. We find a surrounding area in the sequential flap here. So then you can rotate, find appropriate, then you can do the sequential flap to close on the sides. You can see the first stage, then second stage, we put the expander in the forehead area. So then we try to do the nose reconstruction. So then the second stage, we do the nose reconstruction. So 16 months post-operation. So the patient came to me again. You can see the nose is quite good. Also the flap is quite good. Also very thin. But the problem is the color is not good. It's not similar. So the patient asked, so Dr. Zhang, why can I have the similar tissue and the color of the cheek? So then we have a very brave design. So we prefabricate another side, the normal side, the superficial temporal facial flap, and then rotate this into the normal cheek. Then we put the expansion. So we expanded the normal cheek. So after a couple months, then you can see after the flap maturing, so then we harvest. So before the surgery, we do the CT angiography and we do the thermal imaging. You can see the vessels is inside. Then it's very easy to do the flap design. So you can put the vessels in the middle of the flap. Also, you can see how far the vessel is reached. So you can see it's make your flap more safe. So the second stage, so we harvest the cheek, the expanded the cheek flap. So then don't rotate, then we transfer to the other sides. So this tissue is similar, it's the same tissue. Right cheek and the left cheek in the same tissue, the same color, also the thickness the same. So 3 weeks post-operation and the 3 months post-operation. You can see this is almost the same. So it is the end of reconstruction. So the next stage, we do the facial paralysis, the facial nerve reconstruction. So this is another case I showed 3 years ago in ASIM. I did the best case. So this is the girl abandoned by her parents. They call her a little monkey schoolgirl. So it's a giant nevus. giant nevus. Then you can look her. You can see. So almost the giant nevus everywhere. So there's no donor sites. The patient wants. The girl told me, okay, Dr. Zhang, for me, I just want to go to the school. The students not juke on me. So I just want to resurface in the face and the neck. When the exposure outside, I can wear the shirt and the students not juke on me. So it's very, 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 very simple, but it's very, very difficult for us to reconstruct the cheek and the neck because there's no donor sites. So you can see only the right cheek and the lateral thoracic, the right thoracic area, and the right abdominal area. There's a little bit, normal. It's not not invasive. So our surgical plan is prefabric and pre-expanded. So we prefabricate and pre-expanded the right cheek and try to reconstruct the left cheek. And we prefabricate and pre-expanded the right lateral thoracic area and try to reconstruct the anterior neck. And the right abdominal area is to the posterior neck area. So the first stage, we harvested. You can see we harvested the superficial temporal facial flap and then rotate to the cheek area. Then we insert the expander under the facial flap. Then we do the prefabric and the pre-expanded flap. So then, okay. Also, this one is we put some stitches. This is the margin of the facial flap. So this you will leave a little bit small scars. So this is a trick. When you the second stage, after expansion, you will not know where is the margin of the facial flap, but you leave some small scars. So then you can find the margin of the facial flap after expansion. So then for you, it's very easy to harvest the flap or design the flap. So this is the lateral thoracic area. We put the 400 cc, and then we harvest the serratus facial flap with the lateral thoracic facial flap. It's based on the serratus branches of the thoracodorsal artery. So then we put the expander underneath. So then we put another 300 cc in the right abdominal area. So we dig out the type vessels or some branches, the medial branches, the lateral branches, some fascias, and then we insert the tissue expansion underneath. So after 6 months, the flap is matured, also reached to the desired volume. You can see this. Unfortunately, the right abdominal area, the expansion is leaking. So this abortion. So only the right cheek and the lateral thoracic area could be applied. So then the first stage, we harvested this prefabric and expanded the cheek flap. So you can see, when doing the surgery, you can see you can close the donor sites. So then we resected the whole flaps. So then we resected the giant nevus in the another side, and anastomosis to the facial artery. So this is the first stage after operation. You can also see some pigmentations, but after a couple months, the pigmentations after the wear vascularization, so the color will change. So you can see the colors change. So then we do the lateral thoracic expansions. So we try to resurfacing the whole neck area. You can see we resected the whole neck, the submental and the anterior neck area. So then we harvest the flap based on the thoracodorsal artery. You can see quite big of the flap. You see the nevus. So the first stage during the surgery. Also, when you harvest the whole flaps, you cannot close it. So then you can find some perforators from the intercostal. So then you do the propeller flap to reconstruct the donor sites. This is the post-operation follow-up. You can see the sequential flap. So then we do the debulking of the flap, the neck flap. So this is the final results of this. Yeah. So the girl can go to the school. So the students not joke on him, not joke on her. So this is our goals, right? So I win this the best case in 2007. For the total face unit defect, it's like this. Maybe in US you will apply the allotransplantation, but for our hospital, we don't have the permits to do the allotransplantation. We still struggle and struggle to find a way to get this permission for the allotransplantation. For this one, so we put the expansion 500 cc in the anterior chest area. So then in the second stage, you can see we try to resurface the whole. So the bilateral cheek, nose, up in the lower lip. So before the surgery, we detect 2 perforates from the intermammary artery, the second intercostal perforates, and the fourth intercostal perforate. So then before surgery, we try to we do the 3D printing. Then we print this. So before surgery, you can find the 2 perforators. Also, we do the thermal imaging. You can see it's quite good. The thermal imaging is very, very clear. Also, this is very easy and cheap. Just 1 second, and you can see the. So this is a very important information for us for the flap design. Also, we compare with the color Dopplers. So the red line is the thermal imaging. The black line is the color Dopplers. So the thermal imaging could provide the more information. So how far the vessels reached. So during the surgery, we insert the printing mask. You can see. So then we can design the flap, how big the flap. Also, this is very important, for us during the surgery. You can, where is the anatomic point, like where the margin of the oral commission, where's the columella points, also where there's the lateral area points. So then we divided the 2 perforates from the internal mammary artery. Also, we clip one side. We clamp one side. We block the 1 perforate, and we see how this blood circulation of the whole flap. It's good. Also, this ICG and the thermal images. So then we elevate the flap above the fibrocyst to achieve the more thinner of the flap, and the 2 pedicles, the second and the fourth intercostal perforators. So then transfer to the face and anastomosis to the bilateral facial artery in the vein. So we resect the whole the cheek, up and the lower lip, also the nose. So then we put the flap and anastomosis. So this is the patient that I just finished last month. So we still need more revisions or debulkings. Also, the second stage we will put the cartilage, and we will rotate the lateral the nasal ala to create the nose. So in the end, I would say, so although we are very, very good in microsurgery, we can anastomosis is very small vessels, harvest the flap everywhere, but we still face the problem because we lack of donor site in the human body, right? And we lack of the financial resource in healthcare, and we lack of the time resource. So the concept is, so we try to open up the new resource like allotransplantation, tissue engineer, stem cell. So we have the resource from outside. The second status is maximize the existing resource. like I introduced today, is like expansion, prefabric, pre-laminate. So this kind of surgical technique is like a maximum the existing resource. The third is regulate the fluid, like a perforated flap, super micro. So you just save the donor site. This is to regulate the flowing of resource. So the pre-expanded and the prefabric. So this kind of surgical technique, this kind of flap, stopped it. It's this kind of surgical procedure. It's like create a new flap. So this is fulfill the principle of how to maximize the existing resource. Also, pre-expanded and the prefabric technique is make the ideal donor site to be a real ideal donor site. Thanks, Dr. Safran. So thanks. It's very honored to be invited and to share my experience for the face soft tissue.
Yixin, thank you so much for another incredible talk. I think the work that you're doing truly makes an incredible difference in these patients' lives. And I want to thank you for advancing our field the way you're doing.
Thank you, Safran. I hope I can host you in Shanghai, maybe the end of this year, maybe next year. Yeah.
I would love to visit, and unfortunately last year it didn't. I had a conflict, so I couldn't make it. But I would love to join you.
Yeah. I understand. The last year you're very busy. You know, very busy. Yeah.
I wanted to read a comment in the comment section. Professor Scott Levin typed a comment. Greetings from Philadelphia. So happy to see and hear you tonight. Regards to Wendy, Yvonne, and Tiger Scott. Sushi for your brilliant lecture, Scott Levin.
Thanks. My mentor is always yeah. He's so good to me. You know. So I love him. Yeah.
And he loves you too. I had a question to ask you, which is a question that I've asked many of our speakers who do these very big cases. There has to be some fear involved when you do these massive cases. And so how do you deal with the fear as a surgeon of embarking in a new field and doing such a big operation on someone?
Sorry, you mean in the theater?
Yeah, so just as far as the surgeon doing such a big case, there has to be a little bit of fear. So how do you manage that fear?
Okay, so just practice, be brave. You know, at the beginning, for the case, I transfer the normal side to the defect side. So I just think, if I lost it, then I can do the skin graft to this. So this you have some safe ball in the backup. Yeah,
that is true. But your results are absolutely beautiful. I mean, I think your patients are very lucky to have you as their surgeon.
Yeah, so it's a little bit different. In US and China, we have a lot of burn cases. Yeah, in the factory. So we normally 1/3 of our cases is the burn cases.
Yeah. Professor Bala from Chennai, India, I see your webcam is on. Did you have a comment or question for us?
A comment and a question. An excellent presentation. I like to know any trick in removal of that capsule that formed by the tissue expander. You have the entire capsule, you remove in totality or you remove only partially, because many times we find it's very difficult to remove the entire capsule of the tissue expander.
Yixin, the question was whether or not you remove the entire capsule of the expander or if you leave it.
Yeah, so normally if you want the more thinner flap, also you should above the fibrocyst, also if you without the fibrocyst, so normally after surgery they will shrink. So if you remove this, so you will try to avoid the second shrink of the flap. Yeah. So normally I removed it. Yes.
Okay, thank you.
Thank you, Dr. Black.
Any trick in removing that? Any trick in removing that? Because many times I find it difficult to remove that.
Okay, thank you for that comment, Professor Bala. Greg Buncke, I know you're online. I was going to call on you for a question or comment for this fantastic lecture.
It really was a fantastic lecture. Can you hear me, Yixin?
Thanks, Dr. Greg. Yeah.
Yes, fantastic lecture. You have more courage than all of us together. With the size of the flaps that you have are just incredible. And then also just being able to get your patients to live with the biggest expanders I've ever seen. It's incredible. I don't know how you keep them motivated to try to keep the expander getting bigger and bigger. I've never seen such huge expanders on patients like this. It's incredible. I think some of the most important art is the secondary operations that you do in terms of, doing the debulking. Do you use liposuction, or you use direct excision? And how do you keep scar formation from getting too out of hand? I know that scar management is a big part of your practice.
This is very, very good questions, so thanks. So for the second stage, we do, sometimes we do the liposuction, but I prefer to, when I open this, I do the debulking directly. For the scar, so we have laser. We do a lot of laser for the scar management. So the early stage, when you just we applied the post-eye laser normally 2 weeks right after the stitch moves. So we should try to inhibit the vessel growth. So after 2 or 3 times, normally every month 1 time. So after 2 or 3 times, we apply the CO2 to release the scar contractures. So we because in Asia people we have a lot of scar problem as a hypertrophic scar problem. So this is a very, very good question. We always are concerning about this. Yeah. Thanks.
Thank you very much. Great,
thank you.
Great talk. I love the way you use perforator these propeller flaps to close your donor defects. That's a novel idea. Great idea.
Thank you. Yeah.
Yixin, I wanted to thank you again. Another fantastic lecture. I've seen you give many lectures, but I think this is right up there with the best of them. I think the advances that you've made in our field are tremendous, and I think they make a real difference in patients' lives. So thank you again for being with us. It's really been an honor, and I really hope to be able to see you soon in person.
Yeah, thank you, Dr. Safa. I hope to see you soon. Yeah.
Excellent. Thank you so much. Please say hello to all of our friends in Shanghai.
Yeah, thank you so much. Yeah.
Take care.
Thank you again, Yixin. Nice
thank
to
you,
see you.
Dr. Green. Yeah, thank you.
Bye-bye.
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 Bye-bye.